Hi, my name is Dr. Catherine Dean. I'm an Associate Professor in Research at the University of East Anglia. Today's talk is going to be about looking at disability access, starting in labs but then going wider. In other words, how to access brilliance. I did a survey of lab accessibility in the spring of this year. I recruited 152 people to respond to it who had an interest in lab access. 55% of them were disabled, and most of them had experience of working in labs. Those that didn't do things like making lab equipment, etc. And most were UK based. There was a dominance of biology and biomedicine labs, and most of the labs were based in university or healthcare settings. When we asked the disabled respondents what their disabilities were, invisible impairments were definitely the most common. Unfortunately, the summary of the survey can be summed up in this quote: "My lab broke me. I hope others are better." Unfortunately, we found that structural access to labs and buildings is poor. The behaviour, attitudes and knowledge around disability and access is very poor. Initiatives to change ableism are generally regarded as tokenistic and ineffective, and web pages and conferences that result from the work done in those labs are often inaccessible. Unfortunately, this overall poor access leads to really poor safety, unlawful practices, poor recruitment and poor retention. So we created a suite of access guidelines from this survey. Most of the guidelines are not original. They are poached from various other guidelines, but brought together in the context of lab access so that it's stuff that's relevant to lab accessibility. And we've looked at both the structure of the labs, the equipment that's used in the labs, the protocols that are run in the labs, the dissemination of the results from those labs, so that's events and publications and web pages, and also working practices. So in other words, the HR of running the personnel in those labs. What did the survey tell us? Well, unfortunately, we're getting the basics wrong. Less than half of the labs had ergonomic adjustable seating, and most of the labs did not have any height adjustable benches or equipment. Toilets, a third of labs did not have an accessible lab within the building, or at least within the knowledge of what the person was responding to the survey, that it was in the building, so probably not close. Only a quarter of those toilets actually had decent visual access, so differentiation of colour, so they were white boxes. So if you go in as a visually impaired person, you struggle to find the toilet. 12% had a changing place accessible toilet. This is a large 12 metres squared toilet with a hoist and a bench. And that was much higher than we thought it would be, but quite a lot of these labs were associated with hospitals, and we think that's where those were mostly. Mobility and sensory access. So whilst we had step-free entrances for most buildings, we still didn't have it in 12%, so that's over 1 in 10. But 18% of labs had step-free access. So that's over 80% of labs did not have step-free access. So immediately, just because I'm a wheelchair user, I can't even get into 80% of labs and work there. 6% of buildings didn't have access to higher floors, and whilst that is a small number, bear in mind that obviously that can be multiple higher floors, so it can exclude you from a substantial number of workplaces. Powered doors, 75% had them at the front door, but bear in mind that's still 1 in 4 didn't. But as soon as we go to the internal doors, we've got less than a third had internally powered doors, and 1 in 10 labs had a powered door. And I can certainly speak as a wheelchair user that pushing open standard doors is a very rapid route towards getting a dislocated shoulder. It's really hard work. Even if you could get into the labs, only a third of them had a turning circle. The hearing loops are only available in a quarter of buildings and 8% of labs. There is very infrequent good colour contrast. Benches are matte in 65% of labs, but that means that a lot of labs have gloss benches, which the glare can be a really substantial problem for anyone with any level of visual impairment. And even basics such as providing task lighting is only available in less than in around 1 in 5 buildings and labs. It's really not acceptable. Fire safety is where it started to get really quite scary. We had 13% having a fire safe lift. Now that's fair enough because BS 9999 came in 2017, where a lift can be used for emergency evacuation and it is smoke sealed and all the rest of it. And that's quite a substantial investment, particularly to retrofit into a building. But obviously, it really makes it very much easier to evacuate anybody who has challenges in evacuating normally. However, when we asked about things like evacuation chairs, we found that less than half provided them, and 20% of people said, we think we need them, which is starting to be worrying. 43% had dual alert fire alarms, that's audio and visual alarm symbols. And again, you've got this 35% that didn't have it, but did want it. 60% of buildings had a ground fire exits, all of them being step-free. Now, it is challenging, particularly with older buildings, to get every single fire exit step-free. However, consider, in the event of smoke and flames, you want to be able to get out of the nearest door. And if that door has steps down out of it, again, the wheelchair users and those with significant mobility impairments cannot use that door. What was really scary was we asked people, do you need a PEEP, a personal emergency evacuation plan? Now, you need a PEEP if you have significant mobility, visual or hearing impairment. So of the ones that we surveyed, 38 people responded and said, yes, I need a PEEP. I said, do you have one? Only 8 people in that list had one. So that's 21% of people that we surveyed actually had a PEEP who needed it. And we asked about adapted lone working policies. Again, 36 wanted one, but only 11% actually had one. Now, I find that personally really quite terrifying, quite annoying, to put it mildly, and bluntly, this is unlawful. Now, think about it. When was the last time you actually had a discussion in your health and safety committees about PEEPs, about lone working policies, about the ability to get everybody out of the building within a reasonable time frame, irrespective of their level of impairment? My bet is that that's rarely come up, and I would really strongly encourage you to have that conversation with all of the institutions that you are responsible for. Disability accommodations. So this was for the respondents that needed them. I suddenly realised how unusual I am. I've managed to shift the infrastructure of an entire campus and had impact elsewhere, castles, museums, trains, etc. But of the people that we surveyed, only 11% had actually managed to get building infrastructure changed to be adapted for their needs. The same percentage managed to get accessible parking bay. Now that really is a pot of paint, a bit of readjustment of the parking lot. That really is unacceptable that only 1 in 10 people managed to get an accessible parking bay when they needed it. Now, it's better in terms of the accommodations in the way that people work, sort of flexi-time or part-time. We've got 65% of people that did do that, but that means that over a third didn't. We have only 30% having equipment adapted that they needed, and 35 having adaptations to tasks, so them being adapted or handed over to others. So you can see that disabled people are not having their reasonable accommodations met. They're not having their working environment adapted in the way that they need it. And this is within a culture of long working hours. 64% said yes, that was the culture of their labs. But bear in mind this additional impact on disabled people, because 83% agreed that this was detrimental to them managing their disability well. Unfortunately, we started to go into bullying and discrimination behaviours, and we had a third of people that had witnessed bullying of a disabled people. 44% of our 55 disabled respondents had been bullied in the last 10 years. 22% had reported such bullying, and 53% would feel comfortable speaking out about disability, bullying and or discrimination without feeling they'd have negative personal consequences. However, this may be in part because they didn't feel that the concerns would actually be acted on in an appropriate manner, which 47% did believe. So, and only 27% really believed that disability had no negative impact on promotion prospects. So if you're a disabled person, you're quite likely to be bullied, you're quite likely to witness bullying, you're quite likely to have that bullying reported, but the likelihood of anything being done that is actually an appreciable improvement is fairly small. And yes, your promotion prospects are impacted just by your existence in this world. However, there is a huge desire for change. 78% wanted equality, diversity and inclusion initiatives for disability to go further. Only a third of people felt that EDI initiatives they'd seen had been successful in action, and just over half felt that most EDI initiatives were tokenistic. There is a great belief that grant funders need to require high access standards in the labs that they are responsible for building and refurbishing, 88%. And 91% believe grant funders should require all labs to meet a minimum disability access standard. So there is a great desire for change. There's a recognition that this is an unacceptable standard at present, and bluntly, there is an expectation that funders have a huge responsibility and appropriate levers for change. So, what do I recommend from this? Well, I'm being asked by quite a lot of people, what should we do next? Well, here's some ideas around disability access behaviours. For the immediate term, say, give you up to 5 years for some of these. Obviously, there should be an audit of PEEPs and lone working plans. It is unacceptable that the work policy is effectively burn, baby, burn. That is not an acceptable or lawful standard. TUC has created a wonderful reasonable accommodations passport. I would highly recommend that this is implemented as part of everybody's annual review processes, because it normalises that everybody has variability in their personal context as to whether or not they need some flexible working, whether they need to adjust some of the tasks that they undertake, or whether they need to put down some of the work that they've been doing because they find it personally damaging in one way or another. It also makes sure that we also need to normalise reasonable workloads and flexible working. And by that I do include working from home and hybrid working and all the rest of it. We really cannot leave the lessons that we learned from COVID times, that a lot of work can be done in a flexible way and it doesn't require presenteeism to actually be achieved. Let us not go back to that, because for disabled people that has often been a massive boon and massive improvement in working terms and conditions. Everybody needs allyship and bystander intervention training. All staff are responsible for fault reporting, but also for challenging and changing the environment they work within. But bluntly, if you see a powered door that isn't working, it is your personal responsibility to report that to estates to get that fixed. You shouldn't wait until the poor person in the wheelchair is struggling to open that blasted heavy door. We need mentorship programs for disabled scientists so that we can support them to fight back and be resilient against a very ableist and damaging culture that currently exists. We need to do events like access hackathons, pride events, etc., to really highlight that we as institutions and organisations recognise and are proud of the achievements of disabled scientists. And we need to make sure that people have access to external advocacy expertise, whether that's trade unions, whether that's specialist disability advocacy, not just for the things that are within work, but also for the things that are outside of work, because actually getting your PIP, actually getting a Motability car, actually getting a blue badge, all of those external things can mean your capacity to work is massively impacted, positively if you get it, or negatively if you don't. Structural targets, immediate ones. Why not let's publish some guideline standards for new builds and refurbishments. Let's start an aspiration for improvement. Let's do that for equipment and its placement in a lab. There's no point in having a lovely accessible piece of kit if you then place it on a non-height adjustable bench. We need to make sure that institutions have the appropriate evac chairs or appropriate alternatives. We need to make normal the use of microphones and PA systems and portable hearing loops in every sort of event and meeting, so that anybody with a hearing loss can actually hear what's going on. Ewan's Guide red cord cards, as seen in this picture, are incredibly effective at stopping all the red cords in the accessible toilets from being tidied away. We put them on the 200 or so accessible toilets we have on our campus and pretty much immediately stopped all of the toilets being red cords being tied up. We need to look at colour contrast in accessible toilets. Basically, invest in a pot of paint, a different colour, and paint the wall behind the toilets and behind the sink a different colour. And then the visual inclusivity of those facilities will be massively improved. We need to look at longer term targets in terms of structural accessibility. I would strongly suggest that funders need to start stating now that in 5 years' time there will be minimum access standards that would be required before an applicant is eligible for funds, and that this should include mandatory training and audits. We need an accessible toilet in any building that has a standard toilet. If work is being done, there should be a toilet in that building. We need dual alert fire alarms. We need equipment connectivity standards so that we don't have to have highly specialised, highly accessible centrifuges. We just have to have them having the connectivity to a computer that can provide such a control system in place, so that we can have voice activated controls, we can have eye gaze technology, we can have large buttons, whatever is needed can be in a separate computer to the centrifuge or other piece of equipment. We need to make sure that hearing technology is available. Now here it is challenging because there's lots of different standards and lots of clashes of standards, but we need to look at that and we need to find solutions that are acceptable and can be recommended for the long term. We need to improve the basic ergonomics, the seating, the lighting, the acoustic environment of labs. We need to look at key routes through the buildings and make sure that they have light doors and are step free. We need to make sure that all taps are lever taps and D handles are used on all cupboards. And we would like to have a changing place accessible toilet within a 20-minute roll of any building. In 10 years, we want to up the standards of accessibility that are being required. We want to, bluntly, sometimes we're going to have to disinvest and repurpose buildings that cannot be made to a suitable accessible standard. Where possible, we're going to want to invest in fire-safe lifts and step-free fire exits everywhere. And for most routes, not just the main routes, for most routes we would like to have light doors and step-free access. And let's make that changing place accessible toilet within 10 minutes. And we need to start to look at things like accessible fieldwork, boats, planes, etc. Anywhere that research is done, we need to be looking at that. All of this needs to also feed into the design of research itself. We need to expect disabled participants. Now, as a healthcare researcher, I hate to say it, but bluntly, most healthcare research is not designed for the participants to be disabled themselves. You're supposed to be fit and healthy other than this one disease you have. And bluntly, that isn't the real life expectation of what actually happens in real research. We definitely need good quality patient engagement, patient and public involvement. We need to audit the equality, diversity and inclusion characteristics of both researchers and their participants. And we need to have a standardized way of doing that so that data can be genuinely accumulated from all research that is funded, so we can spot the trends and see if what we are doing is actually having the impact we want. We need to make the written information simple, clear, with text and large fonts with pictures, etc. And we need to have a how we made this project accessible section as standard in an information sheet. Principal investigators, ethics committees need training, and we need a budget to cover the additional access costs for venues, BSL interpretations, captions, videos, carers, travel, food, etc. We need to look at how we fund and how we think about research and how it is done. Flexible deadlines, absolutely. And when those deadlines happen, putting deadlines just after a holiday period means that you lose the holiday period. Now that's sucky enough for most researchers, but for a disabled researcher, that can mean that the bid does not go in, because the holiday period is actually their rejuvenation and recharge period. And please do not state that you're delusional enough to think that researchers do not work through their holidays to put in bids. We need to look at flexibility of the duration and how people work, full-time, part-time, work from home, extensions, particularly on studentships. We need to look about flexibility of roles, shared principal investigator responsibilities in particular. We need to have a separate researcher reasonable accommodation funds so that researchers with additional needs can separately, on achievement of a bid, gain additional funds to support their ability to do that bid, and for those to be approved rapidly and sensibly. We also need a rapid response research access fund, say within 2 weeks. It would be financially inefficient to put in costs for BSL interpreters for on every single bid for interviews. However, if you could rapidly access the funds for that and make sure that everybody that gains the funding from you knows that, then actually you can have BSL interpreters for the interviews that are needed, even if it's in an area where you wouldn't traditionally have expected deaf participants. We need to fund accessible practice for events, conferences, etc., but also consultations and so on. And a few prizes wouldn't go amiss. But we also really need to bring together and develop a consensus on access standards, guidelines and accommodations. We really must not reinvent wheels. We absolutely have to have agreement on accessibility standards that are expected, so that you're not confusing people as to what's required. You're not getting universities going, but if you only bid for that funders' money, they have a lower access standard and we can meet that one. We do need carrots and we do need sticks. This does need to be starting to be highlighted to institutions that it is no longer acceptable to be as inaccessible as they currently are. So we need this common core set of access guidelines, a knowledge repository, common standards, common targets, and a consensus on policies to support, fund and train anti-ableism. EPSRC already have an access fund. Why don't all the other funders have a similar access fund? It is unacceptable that only if you get an EPSRC grant at present that you get access to these monies. That's not acceptable. We have to stop this postcode lottery of which letter set of funds you go for that you get funding. And we must be very realistic and expect political pushback. This is inherently political. We are stating that we value disabled people, and that is not necessarily true of all politicians at present. And we are impatient. We want deeds, not words. We've been waiting since 1995, the Disability Discrimination Act. Everybody talks about the 2010 Equalities Act, but actually DDA was pretty much rolled into that act, virtually unchanged. So we've been waiting a long time for reasonable accommodations, for preemptive actions, and we're tired of waiting. And we want you to act. We want you to act at speed. And we want you to be accountable to your mission statements. UKRI has a brilliant one. Research by everyone, for everyone. Except I don't feel like I'm part of the everyone in that statement at present, and nor do most people with disabilities. Perfect is the enemy of done. For goodness sakes, let's take action now. Let's do it badly, but better than what we are currently doing. Do the best guess, informed by evidence, informed by those that are impacted, so the disabled community, but make sure you just do it. But implement feedback loops so you can refine it and repair it when you don't get it exactly right. For goodness sakes, we do not need randomized controlled trials for ramps. Absolutely, they improve accessibility. Let's get on and get some of this done. Absolutely, let's study it. Let's see if it's having the impact we desire. But for goodness sakes, let's stop dithering about it. Let's stop observing it. Let's start implementing it. And this is my personal mission statement: to remove the barriers to accessing life so people can express their brilliance. Could that be yours? Could that be the funders, all of the funders of every type, all of the Royal Societies, all of the learned societies, all of the universities? Could that be one of their mission statements? There's some references there around disability access and how to do good patient consultation, and also around core values work, so ableism and bystander intervention training. I have talked about this at much longer length in other places, so there's a whole link of talks there. And this is my contact details and the link to the Access All Areas in Labs guidelines. And thanks to all the people that have worked with me and funded me. Thank you very much.